All right, so we'll start up. So thank you for sticking around after lunch, and hopefully we won't get the after lunch lull and everyone will fall asleep. But we're going to talk to you today a little bit about CoreNet and sort of some of the principles and values and considerations that have been emerging over the past 18 months or so as this entity called CoreNet has been developing. And have put together a nice panel here. We have one panelist who may be arriving a little bit late, hopefully, but if not, we'll continue for the panel that we have. So to my right, your left, is Celeste Lee. Celeste is the program manager for patient and family-centered care at the University of Michigan Health System. It's been doing a lot of work. There's Donna.
Right on cue.
Perfect timing. She was getting a better lunch. So Celeste has been doing a lot of work around patient engagement, and CoreNet is working under CoreNet with a particular PPRN, and I'll explain what that is in a moment. To Celeste's right is Lisa Schlegel, who's the Vice President of Community Affairs and Public Policy with FORCE, which is Facing Our Risk of Cancer Empowered. Lisa has also similarly done a lot of work from the patient engagement perspective around issues of privacy and of distributed network-based research. Following Lisa is Donna Cryer. Donna is the president and CEO of the Global Liver Institute, so also represent an interesting perspective here on patient data and the sort of needs that arise when we're looking at a particular need, which is patient need for livers and liver transplants. And I think Lisa, Donna, and Celeste all bring sort of personal experiences to clinical care and how sort of research can inform and sort of advance clinical practice in three different important ways. To Donna's right is Devin McGraw. Devin is a partner and lawyer at Manat Phelps and has done quite a bit of work in this area of privacy. Many of you know Devin well. She's done a lot of both representing clients and I think sort of helping all of us chart and navigate this water of HIPAA and high tech and all the related regulations, and has been involved with CoreNet as the lead of a data privacy task force. And Brad Mallon to her right is a vice chair for research and associate professor for biomedical informatics at Vanderbilt University School of Medicine, and has himself done a lot of thinking around different models for protecting the use of patient data, and has sort of provide some reflections on the panel's presentations that come before him. So with that, I think I'll give a very quick introduction to CoreNet and to sort of some of the privacy considerations that have been developing over the past 18 months, as I mentioned. CoreNet, which was established approximately 18 months ago, sort of has multiple objectives. It's a distributed network of networks. So within CoreNet are 29 different networks. 11 of those networks are called CDRNs, or Clinical Data Research Networks, which are largely groups of different healthcare organizations and hospitals that are working together around the U.S. and every state to sort of streamline the process of data collection and analysis to try to be able to answer some important questions around various diseases. And alongside those 11 CDRNs are 18 PPRNs, which are patient-powered research networks, which are groups of different patients and patient advocacy networks that are, again, working together to develop infrastructure for distributed network-based research. So as you can imagine, this is a very large initiative. It involves several thousand individuals and has sort of a significant investment. It was put in place after the Affordable Care Act was promulgated in several years ago. So CoreNet sort of tries to answer these questions that really require us to create a sort of secure research resource for researchers around the U.S. to be able to use and query in order to sort of help advance some interests that really have been bubbled up through a combination of different groups, patient groups, researchers, hospitals, healthcare communities, providers, who are all trying to find better data to answer questions and improve healthcare. This is done through sort of what we're calling patient-centered outcomes research, which has sort of a comparative effectiveness. It employs a lot of methods of comparative effectiveness and pragmatic clinical research trials in order to sort of try to do research more efficiently at lower cost and better. So PatientCentered has developed sort of some privacy principles, which I'd just like to introduce briefly, and then I'll turn it over to our panel for some stimulating conversation. But to sort of run through some of these guiding principles, I just want to highlight a few. PatientCentered particularly believes that the protection of privacy and data confidentiality and security is essential to the existence and success of health data research networks. As I mentioned, sort of some of the competing interests here are highly sensitive, and PatientCentered recognizes that, and at the same time there's a significant value in being able to do national coordinated research. So building in those privacy protections is central to the work of PatientCentered. Patients and patient advocates in the public are actively engaged in PatientCentered in various ways, and it's deliberate and done both through the PPRNs and through patient engagement in the steering committees and through events like this where we try to engage more broadly within the conversation of privacy and security and the ethics and regulatory questions that come along with doing this sort of research. Fundamentally, sort of as a distributed research network, PatientCentered really relies heavily on the different networks and sites to set policies and practices. It provides sort of overarching guidance and principles and some policies relating to PatientCentered functioning, but at the same time being a distributed network really lets data sit with individual networks, sets up infrastructure for querying of data sets around the U.S., but leaves a lot of these protections to the networks to employ, and with sort of within the context of existing regulations and guidance and ethics norms. So in that context, each individual PatientCentered network is really committed to protecting, I think, privacy in various ways, depending on the nature of their activities and what kind of data they have access to and those sorts of things. Sort of the communication, I think, pathways for PatientCentered are in some ways complicated, in some ways very simple. They have sort of an overarching steering committee which works closely with the coordinating center. Under the coordinating center there are at least, I believe, 9 or so different task forces, and there is one, as I mentioned, on privacy. There's a task force on ethics and regulatory issues, which I'm co-chairing with colleague Jeremy Sugarman at Johns Hopkins, and a number of other task forces, including, importantly, one on patient and consumer engagement. So within this sort of broader structure, PatientCentered's operating to sort of try to develop meaningful policies, meaningful practices to really strike a balance between some of these interests in order to really advance comparative effectiveness research and patient-centered outcomes research. So with that, let me turn it over to Celeste to give a few comments from sort of both a patient, I think, perspective, but also the perspective of someone who has an interest in sort of health research and in health management and improving healthcare quality. And so, Celeste, please.
Great. Thank you very much. Hi. First of all, thank you all for having me here. I have the benefit of being first after lunch, so this is good. Hopefully what I can do is just as Joe said, I come at this space in a very personal way, which I'm going to share with you because I think it does have meaning, and I think it's important for us to understand when we really want to drill down to what we're really talking about. But I also do come from it where I manage and lead patient-centered care for the University of Michigan Health System in adult services. What does that really mean? It means looking at our health system and saying, how do we take some of the provider-centric and system-centric ways that we had delivered healthcare and make it much more patient-centric, which is actually much better for us in this new environment. And to do that, that means I need to engage and bring on patients and families to help us do this work. And we have about 750 who help us do this work. And that's in the entire kind of tripartite mission of an academic medical center, which is education, clinical delivery, and also research. So when we look at research, these are really some big issues that we have. So when people talk about the value and promise of big data, I kind of flip that around and say, for me personally, it's really the value and promise of alleviating suffering. If we even look at developing countries, right, alleviating some suffering. If we look locally, rare diseases, ways in which we have the value and promise of trying to understand treatment, where we already have put in a lot of resources to develop treatments for a specific disease. How could that possibly be parlayed into actually treating another disease that we didn't even know could benefit from this treatment, right? That's where I think the value and promise could come from. And I want to share this with you, and this is why I think the conversation is very interesting. I am in no way, shape, or form ever going to explain to all of you here, especially Devin, I do not understand the privacy and security intricacies that we're going to be talking about. It is an extremely complex environment that we live in. I am just one little person who's a patient who has a disease who's interested. Okay, so I'm just putting that out there for you. But what I do want to share with you is I just want to tell you a quick story. When I was 17 years old, 17-year-old girl, upstate New York, just about to start her senior year in high school. I was in Syracuse, which is a really fun place to be in the summer, horrible place to be in the winter. So we took advantage of the summer. And I had these really weird symptoms that were going on with me for about 4, 5, 6 months. And as you know, at that age, you just kind of feel them. I had migrating tendinitis, pains in my chest. I was having these really weird sensations in my legs, etc. I used to run, and I thought I had shin splints. All these different things happened. And to make a long story short, I ended up being diagnosed with a uniformly fatal autoimmune disease at that time in '82 called Wegener's granulomatosis, which is a vasculitis. And what it did is it caused my nose, my septum to be destroyed, my lungs to start to have holes in them, and my body was also attacking my kidneys and my joints. And so I was progressing really fast. The only way, the information that I was able to Google at that time was the Merck manual. I don't know if you guys ever remember that green book. My mom lived by it. And that's what we had. I was so fortunate. There was no treatment. There was no cure. My docs really didn't know what to do. But the rheumatologist, who was 31 years old, just set up a shingle in Syracuse, New York. He did his fellowship at UCLA, saw Wegener's, more importantly, knew Dr. Tony Fauci at the National Institute of Health was in a phase 3 clinical trial. That was the only way that we would have even found out about something like that. And I couldn't get into the phase 3 clinical trial. But what we did is we worked really hard, and I was able to use the protocol in Syracuse, New York, which was high-dose Cytoxin, anti-carcinogen for cancer, and also high-dose steroids, which were all used for other ailments, and they were using these to try to see if they would work in the Wegener space. And it did. It actually did. It put the disease in remission temporarily, which was great. Unfortunately, my kidneys were gone, and there was nothing we could do about that. So then I started the journey of end-stage renal disease. And I share this with you because this is the cautionary tale of fear and lack of incentive to actually do research in these communities. I started dialysis in 1983, had a transplant in 1986, which was fantastic, and I was very lucky that I was the benefit of a lot of medication, autoimmune medication, that they had improved the outcomes for transplantation. So I was very much a benefit of that. I started to lose my kidney. I also started to become extremely anemic because the kidney secretes erythropoietin. You lose erythropoietin, you no longer make red blood cells. Lo and behold, Amgen, now there's biosimilars coming out with it. But right, so this is a drug that you could give to patients to actually increase their red blood cells, and so you were no longer anemic, which made you be able to live a life. Because I don't know if you know about your hemoglobin or your hematocrit, but if you do, try to test drive a car or a life at a 9 hemoglobin or lower. It's very, very difficult to do. So I was a beneficiary of some really intense research, clinical trials, things going on, to be able to live a quality life while I was on dialysis, right? The challenge is that I had a transplant and unfortunately lost it, came back on dialysis in 95, and have been on it since. So I've been on it 20 years. And I can tell you this, the way in which dialysis affects my quality of my life is no different than what it affected in 1982 as it does in 2015. The lack of research, the lack of being able to share data, none of that has been able to fix what it is we do. Because why do you think that is? It is the least researched disease in the country receiving funding is in the kidney space. Because in 1973, people who had to get dialysis had access to health insurance through Medicare. The only disease in the country that has a benefit and has guaranteed access to health care, to Medicare. They thought that most people wouldn't live very long on dialysis, but in fact they did. It's now that one of the largest expenses that Medicare has. They're very, very interested in trying to do innovation to decrease the cost. But what it also does is, because they're bundling the payments, they're doing all these different ways of trying to get those costs down, it also prohibits or is kind of a barrier to creating innovation in the research space, right? People don't see the payoff, right? They don't see the return on investment. They don't see the R&D. And even though it's different when we're talking about privacy here, and we're talking about big data, and we're talking about analytics and trying to share information, as I was talking earlier with some of our panelists, we need to make sure that we don't enter this conversation in fear, because I know privacy and security and surveillance initiate a level of fear. We also have to look at the positive outcomes that can happen to be able to share this information for the first time. Really, to be able to say, there's this young woman in Syracuse, New York, who's 17, who has these symptoms and is looking to do XYZ, and they'll be able to have access to information that says, oh, if they take this drug at this time, they will have these side effects, and we know that we can treat them very well, right? So that's on the rare diseases, but I argue that it's also going to be on the non-rare diseases. It's going to be on diseases and things that we think are rare, but in fact, they were just underdiagnosed. And I could say, like, people who have, I think it was, not the COPD, but it was one of the groups, sleep apnea, the sleep apnea PPRN. And they were telling me things, the number of people in this country, I would say worldwide, that are pretty much being affected by sleep apnea is huge. And what is the cost? What is the back-end opportunity cost that we don't even know is happening because of that, right? So if we actually have access to some of these things, I think it's really important. I think it's very important, actually. And so one of the groups that I'm on is the Patient-Powered Research Network for Vasculitis, right? And I'm on this group for very rare diseases. And I think when we start talking about these issues, what we're really talking about is the trust relationship, right? The trust relationship with our providers, the trust relationship with our healthcare system. I argue the trust relationship with our country, with our nation, with our lawmakers, that we need to make sure that when we enter into this trust relationship, we're talking about transparency. Just tell me what you're doing and tell me why you're doing it, okay? Accountability. Tell me if you mess up. Share with me if something happens so that I know, right? Then you want to make sure that you engage me, right? You engage me as a citizen and as a patient on what it is that we're trying to do, because all of this is about the common good. It's all about public interest. And all of us who are patients, I'm speaking for me, and I would speak for a lot of my patient advisors, we want to enter into these things. You know, when we're talking about privacy, and as Sue Sheridan and I were talking about earlier, patients get privacy and security kind of combined, right? It's like a braid for them. They don't get the intellectual difference between, well, security's this and privacy's this. They kind of think, I don't mind you sharing stuff, but just make sure my data is secure, right? Or I don't mind you sharing some of these things as long as I'm de-identified. You don't know who I am, right? That's the most important thing. We don't want you to be able to come back to me and in some way make my life worse or my family's life worse or my employment worse at the same time that I'm trying to make things better for other people and myself, right? Because it's really a risk-benefit issue. And when I say risk-benefit, it's not only the treatment. When patients are trying to, in the healthcare space, when you talk risk-benefit, it's usually talking about, you know, what is the treatment you want to give me and what is the benefit for me? And do I want to be able to, do I understand that, for one thing? Do I understand myself enough? And are we having a good enough conversation with my physician that we can actually have this discussion together? That's normally how we're going to talk about risk-benefit. But here, and what I've been giving a lot of thought when I was going to talk to you this morning, is we're also talking about risk-benefit in the privacy space, right? So what is the risk of me actually sharing, you know, just doing the normal base of me going to my doctor and doing dialysis? You collect all that information on me. By the way, USRDS, I've had my information being shared forever. Okay? You talk about CMS and USRDS, there's people, health researchers all over this country that have access to my data as a Medicare data specifically on dialysis. They know everything, right? But it's de-identified supposedly. And so the question is, this has been going on for a very long time, okay? But the risk-benefit is, you know, what's the benefit of the common good of us being able to make new knowledge and share information and affect population health, public health, all over the globe, and what's the risk to me if I look at myself individually? What is that risk? What is a cautionary tale? What is my concern? Right? I want to be able to be a part of the conversation when we talk about engaging patients in a meaningful way so that I can really understand what the risk is. And some people don't even know. Because what I want to say is, okay, let's say I get identified and it's going on. What is the risk for me? I don't know, right? But there are populations for people where society has judged that illness as a very negative thing. People who have HIV, people who have mental health issues, right? People who have sexually transmitted disease. Things that society is going to judge them and could actually make them lesser than is the risk. And we have to be very careful of that. People who have Wegener's granulomatosis and might get end-stage renal disease, what is the risk for me? And I think about that. Okay, so I know it's such a short time, but what I want to say is I also sit on the National Patient Council for PCORNet, and I am on the PPRN, as I told you. I feel happy and honored to actually have my voice as a part of these really wonderful patient advisors that are part of this. We've been working on, for the last year and a half, an aspirational guideline document that is really spelling out what patient-centered consent and autonomy might look like, right? What does patient-centered transparency look like? What does patient-centered privacy look like? And what we're trying to do is we're a collective group of patients, and we all come from it from different angles and different thoughts. And we're together. We've been working, and Devin's been extremely helpful with us and looking at this document. Because as I said, we've had a lot of education, a lot of discussion and conversations. We've had people internationally talking with us so that we could really try to understand, because this is a huge responsibility. Like 450 million Americans in the country, right? And there's 7 or 8 patient advisors on this council, on this really big PCORNet, and we take this really large responsibility of trying to represent and making sure that this aspirational document, and then I just want to share again, is about trustworthiness and about putting trust in the system, and how can we actually help people spell it out that this is, as a patient and as a citizen of this country, this is what I hope we aspire to in big data, to make sure that all of our privacy is protected. So with that, I will stop now. But thank you.
Thanks, Thank you. So I'll turn it over to Lisa to give her perspective and comments on interacting with that patient data.
Thank you. Thank you very much. So much like Celeste, I approach this from both a personal and a professional perspective. A little bit about myself. I am a BRCA1 mutation carrier. Angeline and I could be cousins. I learned of this mutation in 1999, and the ability to test for these mutations had only been available to the public for about 2 or 3 years. So at the time, there was very little information, very little understanding about what it meant, and a lot of concern about privacy and discrimination. I was told not to share this information or let it be shared in my medical records because I might lose my health insurance. I was told not to convey the information to my employers because it could be held against me at some point and I may risk my job. Things have changed a lot in the past 15 years, for the better, by a long shot. But there are still things that we need to do and still things that we need to be conscious of, and I think that's why we're all here in this room today. So from a professional perspective, I work for FORCE, Facing Our Risk of Cancer Empowered. We are a patient advocacy organization. It's been in existence for 15 years, and we represent the hereditary breast and ovarian cancer community. We cover the BRCA mutation carriers as well as other mutations that we can test for now, things like PALB2 or Lynch syndrome. But the main cancers involved are typically breast and ovarian, as well as prostate and pancreatic and some melanoma that fall under that umbrella of these HBOC or hereditary breast and ovarian cancer syndromes. This population, we don't want to pigeonhole it or to categorize it and say, well, you know, everybody in our community feels this way, because you can't make those types of blanket statements. It's a very personal thing as to the level of comfort an individual has with sharing their information. And we've been able to address a lot of these issues for our community with law. You know, we've got the HIPAA laws, and we passed the Genetic Information Non-Discrimination Act. So those have been great steps. And we're making a lot of progress now. They're talking about using tumor markers to guide treatment, you know, and using these genetic and genomic factors. So we're moving in the right direction for personalized medicine. We're trying to protect our population. But in some cases, we're still encountering issues. There's some legislation right now that's in Congress. It's before the EEOC that would penalize individuals who do not want to share certain information as part of wellness programs. They are actually going to be pulling back some of the protections that are provided under the GINA law and under ADA. For what? Because to encourage the participation in these wellness programs, somehow we've undermined the existing laws that are protecting people. And so while we think that everything we're doing is really aimed at protecting the individual, sometimes it has backlash. And so this is the type of thing that I think our network, our PPRN, is trying to be very conscious of in representing the hereditary cancer community. We know that the growth in the use of electronic health records gives us the unprecedented ability to harness data and to achieve better outcomes. But based on the experiences of our community with concerns about genetic privacy that, you know, have deterred people from getting genetic testing and still does, even if it's not a valid concern, it's based on the individual perception. We worry about if that information could somehow be used to discriminate against the individual who maybe carries these mutations by an employer, by a healthcare provider, by somebody providing life insurance or disability insurance. So even when we're talking about de-identification, there's always the question, well, can somehow, via my birth date or my social number or anything else, can that information come back to haunt me? And so these are the types of issues that I think we need to be thinking about as we're discussing these big picture issues. Data sharing, absolutely. It's the only way forward. But we have to consider the patient perspective at the micro level as to what their real concerns are. And yes, facilitating better treatments and better options is definitely the top priority, but you have to balance it with the individual concerns. The interesting thing about the networks and PatientCentered and the novel approach that it's taking is that all of these networks are governed by and for the people who are affected. And so in our network, we have a governance of all, you know, individuals, even our PIs are personally affected. Both are breast cancer survivors. One carries a BRCA mutation, you know, and the rest of us are all personally affected. So when we look at the decisions that we're making on behalf of this registry and behalf of this research network and our participation in the broader community of PatientCentered, we are looking at it from the perspective of an individual who is personally affected, as well as the perspective of the broader community. And I think that is such an important aspect, and really the thing that makes PatientCentered so special. And so I encourage everybody here to think about that. You know, with the cancer genetic testing marketplace opening up, there's been exponential growth in entities collecting data through public portals for a variety of reasons. And it's our experience that consumers don't always understand who is collecting that data, how it's being utilized, and even whether the data is being used for research or commercial purposes. So unless we can do a better job of educating the public about the many ways that data can be collected and used, and provide oversight of how these uses are communicated, it's difficult to know if we're really giving people the ability to set their own preferences. Through a lot of these, you know, you go online and you fill out the informed consent and you check this box and you check that box. We need to do a better job of educating the consumer so that they can go into these decisions with their eyes open and make informed choices. And I think that if we invest in educating the public, then ultimately we're going to see better participation and a better comfort level and a better level of happiness with these ideas of electronic health records and big data and so forth. We don't want those negative connotations. We want to associate positive connotations to these things, and I think educating the consumer and the public is the place to start there. So that's our perspective. Thank you.
Thank you, Lisa. So it's a good place, I think, for Donna, for you to pick up on sort of the role of patient engagement in this space of sort of healthcare and health delivery and health research, and you have a lot of experience there. So.
Absolutely. So I am very proud to say that I am an alum of this fine institution, and I certainly took then Dean Areen and Dean Kornblatt's instructions to our class that we could do anything with a degree from Georgetown Law Center, and I think I've tried.
You've done very well.
Thank you. So I hopefully still have a little time left with a little EPO and some other things. So between first and second years of law school, I had a liver transplant. And that changed the course of my life and the course of the purpose of my life and career in ways that I would have never have expected. This room really should be packed. I say that as a patient, I say that as a lawyer, I say that as an American citizen. If only people knew, and it's our job to really tell them, and that this thing called PCORNet, with lots of acronyms and things, this patient-centered outcomes research is revolutionary. It is turning the entire healthcare enterprise on its head. And it can only do that if we get the privacy and security right, because that's the only way that the people who are not sort of professional, personal, patient advocates time to do all this will really understand the potential and the opportunity and trust it enough to participate. So that's why we're here today, and that's why it's so exciting, and that's why we are at this precipice, not only in medical history, but in American history, and if Devin has anything to do with it, legal history, too. A story or two to illustrate. One of the early attempts by patient family members to start, who had lost a brother in this case to hereditary disease, started to put together an online platform to collect patient-contributed data. Many of you know it. It's the Patients Like Me story. One of the early communities was in transplantation, and so talking to Ben and Jamie, I eagerly said, of course I want to participate. I want to make this work. I want to have so many of the things that I know that are part of my clinical record, but they're also part of my personal record, my day-to-day living, what we call patient-generated health data that didn't even have a name back then. But that's what it was. All the things that happen outside of the doctor's office that I know contributed to whether I did well or I didn't. Let's put them all in one place, and let's let the patients decide what gets placed, what qualifies as data. It was so exciting to me that it was the patients who were driving that decision and patient family members who were constructing this. And so I put in my medications, I put in different symptoms, I entered all of these things. It would be sort of early precursors to the registries and the things that would evolve at this state into what PCORNet will be sharing at a really sort of, I'm on steroids, so I would think sort of, I use that analogy sometimes on steroids. So I wanted, the last step in putting together a profile was to put your picture. Some people choose not to. It was really highly encouraged to make it more personal, to make it so that people knew that this was real information from a real patient, someone that they could trust. The picture I chose that I wanted to put up was actually from my wedding. It was a picture of my husband and I dancing. And I wanted to use that picture specifically because sometimes when people think transplant recipient, they think, we're weak, we can barely, we're barely, out in life. And I wanted to show something that was vibrant. We also think sometimes, and I've talked to so many transplant recipients when I worked, always, but particularly when I worked for the United Network for Organ Sharing, which runs the organ transplant system policy-wise for the country. It was sometimes when they're in the midst of that, in the early stages, waiting for a transplant or just after transplant, you can lose hope, or your family doesn't know. Is my future totally derailed? Will I be able to go back and finish law school? Will I have a family? Will I get married? So this picture of me dancing with my husband at my wedding I thought this was the perfect thing to inspire people, and was a great sort of balance for the data. It sort of brought it to life. My husband sort of looked over my shoulder and he's like, "Are you going to use that picture? Like, first you're going to put a picture in the first place, and then I'm going to have to be in the picture. Wait, I don't know if I consented to that." So it made me think about not only my privacy preferences and willingness to share my information, but also it wasn't just my story, it was my family's story, it was my husband's story. And so as we think through the privacy and sharing considerations of this, it's individuals, but it's also the family members. It's also, as we start geolocating things, it's community settings. There are a lot of considerations to do this. And so having the patients and the family members who are intimately involved in this really at the table, helping people, whether they're the engineers or the technology people or clinical researchers, really think through what does it mean to not only be conducting this research, but to be living this research and to participating in it in a very personal way is so important to what we come up with as a policy construct. Second story. Part of my bio and resume that often falls off because it's so long and I'm so much older than I look is that I built a multicultural division for a clinical trial recruitment firm. So in many instances, I would have to devise ways to truly create trust with minority and underserved communities in particular, who you may or may not have heard have not always had the best experiences with clinical research in the past. And so how, for example, just picking one off the top of my head, how exactly would I convince a 50-year-old African-American man who had just had a heart attack to not only give his healthcare information, but to give his genomic data to this study to be sent off to Iceland? That was my challenge. Those were typical challenges. And so I'm like, we can do this, but we can't do it in the way that it's always been done, because that doesn't work for people, real people who don't read 20 pages of legalese consents. Even those of us who graduated from law school, we don't read them. So how is this going to work for people? How is this going to work for people who've just had a really traumatic health experience, a heart attack? How is it going to work for people so that they could not only consent themselves and make a truly informed, meaningful choice and know what that meant, but how could they communicate that to their families, who would inevitably come in and say, "Oh my gosh, dad or mom or whatever, that's impossible, you can't do that, we're not comfortable with that." So these are some of the issues that are at the heart of thinking about what is privacy, what is security, what does it mean? I mean, my two previous panelists here have made such a really great way of enlivening what sort of can be a boring sort of XY axis, and on the bottom axis is sort of uses. So use my information for medical treatment. Yeah, everybody, we get that and everything. Use it for research. Well, maybe what type of research, but the data shows that the American public, we really want it to be used for research purposes for the most part, particularly if it can benefit people like ourselves, other communities, so somebody doesn't have to go through the same thing that I went through. So we're not sort of recreating the wheel. It was either a very profound statement or it was very stupid. When in an NIH Learning Health Systems meeting, I said, well, you know, one of the things we're going to have to do is explain to patients that we don't have a learning health system now, that you're not actually iterating and improving the system based on the information that you already have access to. So I think I have like a cricket manufacturing plant somewhere in my pockets, because that's all I hear sometimes when I say these things. But I think that was true. And to the education process that you mentioned, you have to explain to people that we haven't been learning and using the data that we already have before we start asking for new data and new places to send it and new things to do with it. So I lose track sometimes, but that's can be solved by new and better medications all the time. Or not. So uses for medical research, and then on the far end of the axis, it's like for marketing. So you know, how many of us have wanted to go in and sort of change the form that we sort of sign right by now about have you seen the privacy policies and you get the doctor's office? And I've actually tried to edit those. They don't take too kindly to that. In fact, my cardiologist said he refused to see me if I didn't sign it exactly the way it was written. I tried to explain to him that it wasn't. Anyways, that's another story. But so there's this axis along about the types of uses, but there's also the taller axis contrary about, as you pointed out, the different sort of sensitivities of the information. So. Now, my mother would say, her age would be the most sensitive piece of data that could ever be released about her. But most people would put demographic data sort of low on that. And then highly stigmatizing conditions such as HIV or mental health or those mentioned very high on the axis. And so you really have to think about not just a spectrum of patient preferences in privacy, but really in at least two, probably more, 3, 4 dimensions, but at least these 2 dimensions of sensitivity, over use. Now, I drive a red car that has Liberty Lady plates, so clearly I'm a different part of the. But as I try to aid in the development of policies that serve a wide spectrum of patients and their family members and their communities, not only today but thinking forward to the systems and research enterprises that we would create that we haven't even quite envisioned yet. I want to recognize that there is not only these use cases and scenarios and try to bring those to life for various audiences, including researchers, but the sensitivities. And I think, too, and I'll end on this, that my thought about the sensitivities is to allow patients at the far extent of our technical capabilities, the ability to have sort of granular and changeable consent and sharing options that suit where they are, not only in their particular disease and condition, but where they are in the life cycle of their thinking and living with that condition, because that can change. The days of, blanket, I sign away my rights to data in perpetuity for anybody to use them forever and always in whatever way possible, those are gone. Those are over. We're not going back there. And so we need a more patient-driven, patient-centered, patient-designed, granular level of being able to express the wide spectrum of patient preferences that there are in terms of this sharing, so that we can see the promise of the research while respecting people's different preferences around privacy. And I will end there.
Thank you. That's great. Yeah, I think we're all patients, I suppose. So at one point or another, we've encountered a situation with a physician or a nurse or someone, or maybe a loved one has, where we've had a situation where we were told that we just don't know what's best option here, and that can be sort of a surreal issue in medicine. I think what we're trying to do in PatientGenerated is move research forward in ways that allow more of those situations to be avoided. So I think some of these perspectives are obviously very real, and I think valuable to think about and to involve in the conversations about structurally how do we design a network to be responsive to needs such as this. Structurally, how do we design networks so that these voices can be heard within the sort of processes that are at play in developing policies and guidance and things like that. So PatientCentered tries to embed that within its operational structure. I'll jump over, in the interest of time, jump over Devin for a second, if that's all right, and jump to Brad, and to give us a perspective, a slightly different perspective, the perspective of sort of working from within an institution and thinking about these different models for protecting privacy. So I guess the big question here, Brad, is sort of must privacy compete with data, with medical research and medical care, and how do we think about it sort of in the building structure and infrastructure so that some of these important questions can be answered at the same time respecting the interests that are at play from different patient perspectives about privacy.
Okay, so let me begin by taking off my Vanderbilt hat and putting on my PCORI hat. And in doing so, I think one thing everybody needs to recognize is that, as you mentioned before, PCORI is a network of networks, and each of these networks has their own community. And as a result, PCORI gives each of these organizations or their networks the ability to manage the relationship with that community and build that relationship. This is actually quite intriguing because this was a concept that was initially started, or at least it had started for me in the context of the eMERGE network, or the Electronic Medical Records and Genomics Network, which is sponsored by the National Institutes of Health. And different communities wanted different types of relationships, had different types of expectations, wanted different types of controls set in place. And so an example of this, though, was that I'll use Vanderbilt again. I'll put my hat back on. And in doing so we put together a community advisory board for the research environment that we have, where we use biospecimens in combination with the electronic medical record system. Now, the reason why this is important in the context of PCORI is that that's the type of data that we are bringing to the table in the context of PCORI. So the initial relationship with that community was established such that we began relatively small, and that we did only adults, because we had all patients at the hospital, and we have children's hospital and psychiatric hospitals as well. And it started small, and then there was a test run that was done for 2 years to check to see how well our system was working locally. We rolled it out to about 150 investigators who were using this resource in the system, and when no adverse events were reported, we then rolled it out towards children. And so this type of a relationship was agreed upon by the community. The community ends up having quarterly meetings with investigators as well as administrative officials within the institution. The other reason why we had been a unique place in that regard in the context of PCORI before NIH changed their policies was that we chose to go with an opt-out model in that design, and that was agreed upon by the community representatives after we went through different test runs of opt-in versus opt-out strategies. We found that there were problems not just with perception of how things work, but just even recognizing bias in your own perceptions, in that your ability or certain individuals' abilities to make risk-benefit judgment calls ends up being skewed by the way in which you present things. And so we started as an opt-out model. When the NIH changed or the genome data sharing policy a couple months ago, we switched from an opt-out model into an opt-in model. And it was explicitly an opt-in model. And it was interesting because we actually had questions back from our community of why were they now being asked to participate every single time they were coming in. They actually didn't want this. But we weren't going back. So in the context of PCORI, we have this notion of local use of the information, and then it goes on to the network model, in that you start having sharing of information within the clinical data research networks. As an example, at this point you still have credentialing, you have oversight, you have audit capabilities, the individual de-identification is being done. I'm not going to talk about the capabilities of that, but I'll say that it has been used and I've been a very strong proponent for it. Beyond this, what you might call a semi-local or a network level, you then get into the national model. And at the national model, at the present moment in time, it's an aggregate data sharing model. And at this point, it has to be recognized that this is not an all things to all people type of network, because you can't necessarily do investigations with individuals at that point on the PCORnet level. You instead are looking at to see if there are trends, if there are enough people who satisfy a particular phenotype that might be worthy of a further investigation, because you know that you can do statistical significance with this data. At which point, if you detect that type of a request to participate in a study or for further investigation can then go back out to those networks. That can then be communicated back down to the individuals according to the expectations of those communities. So this aspect of PCORI being a network of networks is key. One thing I did want to make a clarification from, in that you asked for responses, was that I actually want to. I'm not going to disagree with you. I'm just going to tell you that the days of granular...
I've never been disagreed with.
Right, okay. This is going to be fun. The days of granular level control actually, they came and went, unfortunately, and they may have to come back. If you look at new NIH policy that came out a couple months ago, in that we did move away from specific consent for the reuse of information of data that was given out to the NIH after a study, and that it's been pushed into a mandated broad consent model. And so this is a interesting situation to live in that we've actually gone the direction of share the data to as many people as possible, provided that it's permitted to do so by some oversight body. So that's just something to be aware of.
I'm aware. I'm also aware that
it can go the other way. Right.
It depends on who you're dealing with. Right. I mean, you look at, for instance, the IRB that oversees the Genetic Alliance and their peer network, and they do have a registry where people can check, opt in, opt out, readjust.
That's fine. They just.
It's not uniform.
I understand that. I'm just saying that. I'm a recipient of NIH funding. I benefit from it. I can't use that model in this situation. The other thing that I would say in the context of PCORI is that while we don't necessarily have the ability or the time or take the time to educate everybody with respect to every possible protection, this is a challenge that we face in a lot of different sectors. I think if you ask people how banks protect their information or crediting agencies protect their information, you have similar types of concerns. This is partially an artifact of the way in which we have a sectoral community, a sectoral society, as opposed to the way that things work in the EU to a certain degree. But it's also just the aspect that some of these protections they just don't get communicated well. At which point you set up infrastructures and you let people put the protections in place, and then you manage it to the best that you can. So I know we don't have much time left, so yeah. I'll pause there.
Okay, great. Thanks, Brad. So we are short on time, and I know we'd love to actually, if it's all right with our organizers, to give Magdalena a few moments just to say a few remarks in response to the panel. Magdalena Goralczyk is our first responder, and then if maybe there's time for one other question from the rest of the audience.
So super. First, Magdalena Goralczyk, Leibniz University Hanover. I came from Germany in Europe, so a long way, and absolutely happy to be here. It was lovely to hear all of your stories, and really, really nice to listen to you. I was also told a lot from people around that you look so much to privacy in Europe, or to data protection in Europe, and I must say we also look a lot into US. And I think PCORI is definitely something which we can look to because of the sheer scale of what you're doing. And this is absolutely amazing, and I think a lovely, lovely thing to follow. And I was very, very excited when I was asked by Deborah first time, I will be commenting on that. And what I then started doing is, okay, I wanted to understand, how do you actually get data? What is your stance on consent? I started Googling on your webpage, I started searching, and I couldn't find anything. So there is lots of things. If you type consent, you'll find a couple of project proposals, ideas on researching on consent, but nothing on your privacy policy, nothing on consent, really. And even now, listening to you, it was lovely to hear, okay, transparency, confidentiality, trust. Very happy to hear about granularity. But I couldn't really figure out, how do you get data from the patient? What's your stance on that? And that's something which I think worries me. I could imagine worries maybe somebody else here, that we don't really know, because if it's not for you, then who should tell us? If you sit here as, people who are directly involved, and I would be happy to know whether this is simply something which is, not yet communicated enough, or something which is just not something which you can agree on, because it seemed a little bit like it when I listened to the discussion, because it's granular versus blanket consent, for example, which I think is super important. And by the way, I'd go for granular too.
Right.
Okay, that's my 5 cents, and I'd be happy to.
Everyone loves granularity. Do you want me to address that, Joe? So it may not have been, it clearly was not obvious from the discussions, and it's not clear from the website. So the consent issues are dealt with at the local level. So what a distributed network means is that the raw data that gets collected for a research project is done locally, and that's where it stays. And whether or not a particular research project is acceptable to any of these local networks depends on them, and they each have their own policies about how they engage their patient communities in making those decisions. So it is consent per local policy. So all the PPRNs essentially consent in their patient communities. Lisa talked about the peer granular consent. They make those decisions. So it is not one database, one network with one-size-fits-all consent. It is each community making the decisions that work for their communities, both in terms of what research projects are we going to engage in, and in terms of how we're going to handle how we are going to make those available to our participants and decide what data is going to be accessed for those.
If I may, because you used that term community consent, does it mean that a singular patient at each of those sites actually consents, or does it mean that
Yes.
Okay, great.
Yeah, I can tell you from the VPPRN, because I'm on the steering committee for that patient-powered research network, that in fact we did a lot of work on the consent to sign on to the registry, because ours is a registry. Patients do the patient-reported outcomes, PROs, and continue to do things, and they consent to do that. And in fact, there's an additional consent on our site that goes one step further and says, now that you've joined this registry, would you also consent to allow us to have access to your electronic health record?
Okay.
And we give more information about that. And that was actually a very large patient population. I think there's probably like 8 patient representatives on the consent committee.
It's interesting because it's not a homogeneous group. It's very heterogeneous. We work with the University of South Florida, and so we have an academic IRB, which is a little more conservative or strict in some ways than some of the other networks who may have different types of IRBs. So each network of the 18 PPRNs functions separately and has its own method of collecting consent, but it is at the individual level, I think, for all of the PPRNs.
You know what, I'll say, so the other thing that has impressed me about working with PCORnet is that the issue of patient engagement is not just a question of, well, did you consent to this research project or not? Which in many ways is what distinguishes this network from many, many others that exist out there, is that patients are involved in the setting of the policies. Patients are engaged in the prioritization of the research questions. Patients are engaged in deciding what data gets collected. Patients are no longer just viewed, at least in PCORI world, as things that research is done to, but they are part of the research enterprise. And that means that engagement is not just about, well, did you say it was okay for this research project to go forward? It's a much deeper level of engagement.
And
With that, I think we have to close the panel. Thank you very much for your attention. I hope this was helpful.